Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Raynaud's phenomenon. So what is Raynaud's? This is a vasospastic disorder which is characterised by attacks of well-demarcated triphasic colour changes with associated numbness and pain of the digits exposed to cold. So this usually affects the fingers but can affect the toes and other areas of the body such as the nose and the ears, and we'll go into this a little bit later on. There are two forms of Raynaud's, primary Raynaud's, which is known as Raynaud's disease, and secondary Raynaud's, Raynaud's phenomenon. And that can be associated with other conditions, as we will find out. Primary Raynaud's usually occurs in colder climates, as you might imagine, given that this condition is associated with colder weather, usually occurring in younger women aged 15 to 30 years of age. It's more common in those with a family history of the condition, and the female to male predominance has been reported anything from 4:1 to 9:1, depending on the populations studied. Secondary Raynaud's occurs in older age groups, usually associated with multiple conditions, including autoimmune diseases, some of which we've already learnt about, such as rheumatoid arthritis and lupus, vaso-occlusive diseases, certain drugs and chemicals, and also endocrine disorders. May also be associated with the use of vibrationary tools. So you can sometimes see this after someone has been in certain jobs for many years or after retirement, and then they notice the onset of Raynaud's, having used vibrationary tools for quite a lot of their life. The clinical features of Raynaud's really are characterised by this triphasic colour change, which we mentioned before, where the digits go from white to blue to red, and these colours are really well demarcated. You can see this when patients take pictures, or if they are actually having an attack, you can see it quite obviously. The colour change represents pallor, cyanosis and erythema. These colour changes are associated with paresthesia and pain. It does tend to affect the fingers, usually sparing the thumb, but can also affect the toes, the lips, the nose, the ears and the nipples. Secondary Raynaud's can occur with several conditions, as we've said, and does tend to be more prone to trophic complications. So you can get ulcerations, pitting, fissuring of the skin, and in extreme cases it can also lead to gangrene. You may also see relevant signs or symptoms from the underlying conditions such as a connective tissue disease, and this is particularly pertinent in your PACES examination. So for example, if they say that someone's presenting with Raynaud's and then when you examine them they may have features of lupus or rheumatoid arthritis or indeed other conditions which we will be talking about later in this rheumatology series. Here we have a photograph of what the first phase of Raynaud's phenomenon looks like, and as you can see there's a really well demarcated area of pallor, sparing the thumbs. When investigating Raynaud's, it's important to search for an underlying connective tissue disorder, particularly if the presentation is in someone over the age of 30. So in this regard, you would be doing ANA antibodies, rheumatoid factor, anti-CCP antibodies and complements, which are associated with, in low titers, are associated with lupus. I've then mentioned ENA, which is extractable nuclear antigens. And these are specific antibodies such as anti-SCL70, anti-centromere, anti-URMP, and anti-Rho and LAR. These are associated with conditions such as scleroderma, mixed connective tissue disease, and Sjögren's, respectively, and you'll find out more about these in subsequent presentations. Another useful test is nail fold capillaroscopy. So this is where we try to look at the nail beds in extremely high magnification to look at the formation and the concentration of blood vessels within the nail bed, looking to see for any damage or any unusual patterns which may indicate the presence of an underlying connective tissue disorder. Raynaud's can be managed conservatively and medically, as with many conditions. So the first thing to really impress upon someone is the importance of smoking cessation, which can make Raynaud's symptoms more frequent and more severe. Patients should be encouraged to use gloves, particularly in colder weather. And if those are not working, then they can go on to have medical treatment, such as calcium channel blockers. An example of this would be nifedipine, or topical nitrates. In secondary cases, they may require medications such as PDE5 inhibitors, such as sildenafil, and endothelin-1 antagonists, such as bosentan. Again, in more severe cases, they may require the use of prostacyclin or iloprost infusions for severe symptoms, as well as digital ischemia and in the case of ulcerations. So let's do some questions. So the first question talks about an 18-year-old female presenting to her GP with a history of the tips of her fingers, nose and ears turning white in the cold, followed by blue discoloration and then red on returning to the warmth. There is a history of similar symptoms in her mother and grandmother since childhood. She smokes 10 cigarettes per day. She's otherwise well. History and clinical examination reveal no evidence of a connective tissue disease. So what is the best first-line treatment for her? So from this description, it really impresses upon us the triphasic colour change. So we know automatically this is probably a diagnosis of Raynaud's disease. Given that she's so young and there's a strong family history and no other features of connective tissue disease, it's likely that this is a primary Raynaud's presentation. So the options are methotrexate, nifedipine, bisoprolol, smoking cessation, and advise the use of gloves, and sildenafil. So the correct first-line treatment here is smoking cessation and the use of gloves. The use of nifedipine may be indicated if that then does not work, but really the important thing to mention to this lady is to try and stop smoking and try and keep her fingers warm. Second question, which of the following diseases is least likely to be associated with Raynaud's phenomenon? So our options are rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis, gout, and myositis. So some of these conditions we have talked about in previous videos, some of which are going to be talked about in later videos, but you may know about them from your own reading. 4 of them are connective tissue diseases or autoimmune diseases, but option D is gout, and that is not associated with Raynaud's phenomenon. It should be stressed that not all autoimmune conditions are associated with Raynaud's, but the ones that are listed there can, to a lesser or greater extent, feature Raynaud's phenomenon in patients who are affected by them. So thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear from us in future, and see you in our next episode.